I wonder if you want to, either of you, whoever wants to take it, kind of talk a little bit about how we think about using asparaginase. How do we decide how to dose it, drug monitoring, and the various different formulations, I think, are also key questions that I think a lot of people listening to this podcast or reading this article may be wondering about.
So I'll start, and then maybe David, you can follow as the adult oncologist. And I also treat in the United States. And this consensus panel was primarily pediatricians and a few adult treating physicians that were at an international pediatric oncology conference, which really prompted the use. And a couple things. So in the United States, the only regimen for upfront now is pegylated asparaginase. When I started, it was native E. coli. The big problem with that was allergies, and you would switch to the pegylated form. Now, pegylated forms are preferentially used up front. They have the benefit of lasting several weeks, so you get prolonged asparagine depletion, but they are associated with some toxicities, hepatic, pancreatitis, thrombosis, to name a few. And one of the impediments or one of the issues is these antibody-drug antibodies and or silent inactivation necessitating therapeutic dose monitoring. And so we try to incorporate that into our consensus statement, being aware that in Western Europe, they have different asparaginase regimens and different backbones. And outside of North America, Western Europe, the access to some of these drugs, asparaginase and blinatumomab, which we'll talk about later, are limited.
And I thought the consensus statement really mapped out this evolving paradigm of how do you use asparaginase, which is mainly pediatrics, in a world that's kind of merging things. So a lot of immunotherapy is coming from adults, like we see Dr. DiNardo here at MD Anderson, and the data's coming out really thick. And the consensus statement was targeting that.